Good afternoon, everybody, and thank you for joining us. GECO is hosted by the Gastro Foundation in association with Project ECHO and the University of New Mexico. GECO Fellows is run every Monday at 6 in the evening. The chat will be open for questions. Please turn your cameras off if you're not talking and make sure that you're muted throughout. My name's Adam Bootle, by the way, so I'll be chairing the session, and Cecilia Coccia is going to be giving us a talk on colorectal cancer. Over to you, Cecilia.
Hi, evening everybody. So let me just quickly share. And I assume that is sharing now. Okay, so I'm just going to give a brief overview of colorectal cancer. It's obviously more Adam's field. So I've tried to tailor it from a gastroenterologist's perspective. So essentially, about 10% of all annually diagnosed cancers are colorectal cancer, and it accounts for about 10% of cancer-related deaths. According to Globocan 2020, there was almost 2 million new cases worldwide and almost 1 million deaths. It's the second most fatal cancer globally. It's got the highest rates in developed countries. Unfortunately, in sub-Saharan Africa, the true values are largely unknown. There is an increasing burden due to urbanization and Western diet. And as we know, with increasing obesity and diabetes, our numbers are going to rapidly rise over the next 10 or 20 years. At the moment, the age standardized incidence of colorectal cancer in sub-Saharan Africa per 100,000 ranges from about 3.1 in men and 2.9 in women in Malawi, to about 14.9 in men and 14.2 in women in Zimbabwe. It's estimated that the global incidence will more than double by 2035, and the most significant increase is going to be in less developed nations such as South Africa and the rest of sub-Saharan Africa. So this is just a graphic representation. You can see, as we know, obviously in the Northern Hemisphere, that's where there's more than 30.5 per 100,000 new cases. Whereas in Africa, you can see it's largely, the incidence isn't as high, but we also know that our data capturing is not as good as in the first world. And South Africa ranges between sort of a 7.3 to 9.7 per 100,000. So just in terms of the risk factors, in terms of hereditary factors, the hereditary colorectal cancer syndromes only account for about 5 to 7%, and having a positive family history of first-degree relative accounts for about 10 to 20% of cases, whereas about 80 to 90 are actually sporadic. In terms of modifiable risk factors, we know that smoking, processed meat, alcohol, red meat, low veggies and fruits, and an increased BMI and obesity increases your risk, whereas things like physical activity, whole grains, dietary fiber, etc., decrease your risk. In terms of aspirin use, there's been a lot of debate over the years, and the recent US multi-task force, there's a publication in April 2020, where their recommendation was really only if you have cardiovascular risk factors and you're between the ages of 60 and 69, and you're going to use aspirin for over 10 years, would it be recommended as colorectal cancer preventative. But even then, the data is not that great. Other factors that play a role, as I mentioned earlier, type 2 diabetes, male gender, and then IBD, we know is obviously a prominent risk factor. In terms of the microbiome, Fusobacterium nucleatum and Bacteroides fragilis, they're associated with colorectal cancer. But obviously, we don't know what's the chicken and the egg, whether it's the bacteria that drive the cancer or that are secondary to the cancer. I'm not going to go into much detail about the hereditary cancer syndromes. I think that one of the talks coming up is about the polyposis syndromes, and I think one of the surgical talks last week, which I missed, was also about it. But essentially, in a nutshell, you have your non-polyposis syndrome, which is your Lynch syndrome. And remember, that's your MLH1 and 2, as well as MSH6 and PMS2 mutations. You then have your adenomatous polyposis syndromes with like your FAP or attenuated FAP and your MUTYH polyposis. You have your serrated polyposis syndromes, then you have hamartomatous polyposis syndromes such as Peutz-Jeghers and juvenile polyposis. And then you've got a last subset with your mixed syndrome. So again, these only account for about 5 to 7% of your colorectal cancers, but it's important to know about them because of familial screening, as Adam does when he goes up the West Coast, where there's a high incidence of Lynch syndrome. In terms of the pathogenesis, so usually the process begins with an aberrant crypt. There's a neoplastic precursor lesion such as a polyp, and then that subsequently progresses to colorectal cancer over about a 10 to 15-year period. The cell of origin for the majority of colorectal cancers is assumed to be a stem cell or a stem cell-like cell. The cancer stem cells are the result of a progressive accumulation of both genetic and epigenetic alterations that either inactivate tumor suppressor genes or activate oncogenes. And then it's just important to know that there's 3 principal types. So as I've said, sporadic, which accounts for the majority, your hereditary, so both your syndromic and just having a family history, and then your colitis-associated cancers. So just briefly looking at the pathways, your adenoma-carcinoma pathway, which is your usual polyp that then forms a tumor, or in the case of your FAP, starts with an APC mutation. You then get your KRAS and your BRAF, and then your TP53. And these are what we call microsatellite stable colorectal cancers. And the importance of that is that these are the patients that are responsive to 5-FU and platinum-based therapies. Whereas your other 2 pathways, so your serrated neoplasm pathway, as well as your microsatellite unstable pathways, as soon as you've got microsatellite unstable cancer, they're not very responsible to those therapies. And then you have to start looking at tailored therapies and immunotherapy, such as your checkpoint inhibitors. But I'll get into that a little bit later. Just a side note, with IBD, the tricky part is that they don't normally form polyps. And as you know, when you survey them, it's usually flat lesions. The reason is because the sequence is almost backwards. If you look at your adenoma-carcinoma pathway, as I said, it's APC, KRAS, and then TP53. Whereas with IBD, you actually have your TP53 mutation first, then KRAS, and then APC. And that's why they have flat lesions as opposed to polypoidal lesions. So it's important when you're doing surveillance on these patients. Then just another note on the pathogenesis. So it's important to bear in mind that your midgut and your hindgut, they sort of, I would say, breed different types of cancers. So your right-sided cancers generally are more aggressive, and there's an overall worse prognosis. And these are usually your serrated lesions. So just remember, those are they sort of look like hyperplastic polyps. They've got an open pit pattern too, and they're usually covered by a mucus cap. And those are the ones you don't want to miss, because they're the ones that turn into these poorly prognostic cancers. Whereas your left-sided tumors actually carry a much better prognosis. And these are the APC, TP53 microsatellite stable cancers that as I said, they're the ones that respond to 5-FU and platinum-based therapies. So in terms of diagnosis, I mean, this is what we all know, it's our bread and butter. Clinical symptoms, so occult or overt rectal bleeding. As you know, any patient over the age of 45 who presents with rectal bleeding should have an expedited colonoscopy. Anyone with significant change in bowel habits, and specifically loose stools. So constipation isn't usually a symptom of colorectal cancer as much as diarrhea, unless obviously they're completely obstructed. Anemia, obviously abdominal pain, and then, as you know, it's usually asymptomatic until it reaches an advanced stage. And that's why ideally screening or surveillance programs are quite important. And unfortunately in South Africa, we don't have an official screening program. So just in terms of a diagnosis, obviously endoscopy is the method of choice, and identification of advanced lesions is relatively straightforward. However, it's our early cancers that are more subtle. And for that reason, it's important to bear in mind the quality indicators that were put in place so that we don't miss these subtle lesions. And that's things like your bowel prep. So you want at least 90% of your prep to be good. You don't want to miss lesions less than 5 millimeters. You want to have a cecal intubation rate of more than 90%. Withdrawal time should be more than 6 minutes, but I think in the new AGA guidelines, they're actually looking at potentially increasing it to 9-minute withdrawal time. You want an adenoma detection rate of more than 30% in males and more than 25% in females. And your serrated lesion detection rate more than 7%. And then obviously in your units, you should actually be measuring this as well as measuring any adverse events that occur. And then just quickly on best practices, as you know, ideally you want to split the prep to get a good bowel prep. You want to use high definition colonoscopes. Ideally, you want to perform a second look in the right colon. And that's, as I said, is because you don't want to miss those serrated lesions with quite poor prognosis. And then you want to use cold snares for smaller polyps. Any polyps that you're not comfortable with resecting, you'll refer those to someone who, or if you are able to resect, or to refer to someone who can resect. And then obviously your follow-up guidelines, which that unfortunately needs to just be memorized. So then just importantly, when it comes to polyps, it is important to know which features favor a malignant change. And this is from the ACP GBI position statement, which is actually quite a good paper on advanced polyps. But things that you need to look for is larger polyps. So as soon as they're more than 2.5 centimeters, if they're flat or depressed, if there's ulceration and irregular contour or firmness, if there's hard consistency or broadening of the stalk in a polypoidal lesion, if you've got a Paris 2C lesion, so in other words, if it's starting to be depressed or excavated, if you've got a kudu pit pattern 5, or if you've got a lateral spreading non-granulomatous or a granular surface or a nodule in a granular lateral spreading tumor. If there's a non-lifting sign, so in other words, when you put in your methylene blue with colloid, it doesn't lift, it sticks down, and that gives you an idea that there's submucosal invasion or deeper. And then location of the tumor, so proximal to the splenic flexure. Then also in that statement, they just, the importance of tattooing, it's to survey previous excision sites. If there was an indeterminate area of pathology that you needed a second look at, then it's good to tattoo that as well. And then obviously to localize lesions requiring surgical excision. It's just important as well when you tattoo is to just document whether you're tattooing on the anal side of the lesion or not, because if you say proximal or distal, often it can be confusing. So it's better to just say anal side of the lesion. Other options in terms of imaging, so one can do a CT colonography. It's generally if you have an incomplete or an inadequate colonoscopy. So what it entails is the patient still needs to be prepped and they need to still be insufflated with either oxygen or CO2. They then have a CT and a 3D reconstruction is done. And essentially the images here in B is what it would look like. So it is still quite good at picking up polyps. Obviously, the problem then is that you can't actually do anything about the polyp should you see it on imaging. MRI, so the role of MRI is really in the staging of rectal cancer. So patients with rectal cancer can get neoadjuvant systemic neoadjuvant radiotherapy or systemic therapy. And it's important to image that prior. The important thing with MRI is that the tumor needs to be within 15 centimeters of the anal verge in order to qualify as a rectal cancer. And that's with a rigid sigmoidoscopy, not so much a flexible, because as you can imagine, if you have a loop, you might think that it's at 15 centimeters, but in fact, it's actually much further away. And then in organizing an MRI for that patient, you're just wasting time, really. And then CT, As soon as you're worried about metastases, or if you diagnose a colorectal cancer, then you want to stage the patient and scan. Do you want to do a CT chest and abdomen with it? Laboratory values, really the main things, I'm not going to go into all of them, but just a full blood count and then a CEA at the time of diagnosis. Just important because an elevated baseline CEA is associated with a worse prognosis. And it's important to know that concentrations that don't normalize post-operatively might actually indicate residual disease. In terms of pathology, so the pathologist will assess the histological subtype, the grading, if there's lymphatic, perineural, and venous invasion. They'll look at tumor-based markers, so importantly, the mismatch repair in your Lynch syndromes, and that, as I alluded to before, there's implications for the 5FU-based therapies, and also identifying those patients that would benefit from immunotherapy. So in terms of your tumor staging, so on the left, essentially your M1, M2, and M3 is through your mucosa, and then SM1, 2, and 3 is through your submucosa. With SM2 and SM3, the implication there is that there's a high percentage or a chance of lymph node metastases as soon as you have SM2 and SM3 involvement. There has been a recent meta-analysis done that has actually shown that as an independent risk factor, it's not, if you take it alone, it's not actually a risk factor, but that's still debatable. And then in terms of your staging, your stage 1 is your T1 and T2s, your stage 2 is your T3, so it's all the way through the muscularis, and then stage 3 is lymph node involvement, and stage 4 is your distant metastases. When it comes to your rectal tumors, it's a little bit different. So this is a normal MRI of the pelvis. You can see the rectum, and then you have your mesorectum with your mesorectal fascia. And that's essentially what you want to look at to see if a tumor is resectable, because you want to see whether it's gone beyond that mesorectal fascia. And you can see here is a T3 tumor where there's speculation and that area is sort of completely anatomically destroyed. Management-wise, so endoscopically, an en-bloc excision obviously allows for the assessment of the submucosal invasion depth, the differentiation, so whether it's poor or good, or well differentiated rather. If there's lymphatic invasion, if there's high tumor budding, which is also a poor prognostic feature, to look at the deep and lateral margins, and then also to decide on whether adjuvant therapy is required, depending on these risk factors. T1 tumors, so those are your mucosals. Obviously there you want to try and remove them endoscopically. So you can either do an EMR, an ESD, or a full thickness resection. It is, however, important that when you come across these, you need to ask yourself the questions: can it be removed endoscopically? Should it be removed endoscopically? Can I remove it? And can it all be removed in one session or not? And if any of the answers there are no, then you need to tattoo, mark where the lesion is, and refer it on to someone who can remove the lesion endoscopically. And these are just examples. So as you can see, these are your lateral spreading polyps. And lateral spreading essentially is either a sessile or a Paris 2A, so an elevated lesion that's more than 1 centimeter, and the spread is lateral, so it doesn't go along the horizontal. It's on the horizontal axis, not the vertical axis. And then this is just a T1 colorectal cancer. So again, it's to assess the tumor characteristics and decide whether you can take it on. And if you're confident enough, then you can. If not, you tattoo and you refer. You don't want to biopsy these lesions, because you can then cause fibrosis and actually stick the polyp down, which then makes an endoscopic excision much more difficult. In terms of management, so the surgical options, so for colon cancer, what is performed is called a complete mesocolic excision. And what that means is it sort of goes along your embryological margins, and it takes the vasculature that's with that. So for your right-sided tumors, here's a little graphic. It's very much far from my sort of depth of knowledge as surgical excision margins, but these are pretty colored pictures that will help me and hopefully you understand. Generally, the procedures are done laparoscopically, and then looking at rectal cancer, it's obviously much more complex because of the anatomy. And what the surgeons aim for is a total mesorectal excision, which essentially means, as I alluded to earlier, that mesorectum. So you want to ideally take that whole area out with the tumor and the mesorectum. And on MRI imaging, you want to make sure that there's less than a 1 millimeter margin, because once it's more than that, then the patient's not suitable for a resection. And again, obviously the extent of the resection will depend on the involvement of the sphincter complex and the other surrounding structures. And it's debatable whether this should be done laparoscopically. Then surgery can also be done in the case of an emergency. So obviously when there's an obstruction, so either decompressing colostomy or endoscopic stenting can be performed. And then obviously if there's a perforation, then an emergency surgery will need to be done there. The important thing with stenting though is ideally, obviously if it's an emergency and there's no other option, it should be done. But whenever a patient or when you're contemplating stenting a patient, that needs to be discussed in an MDT, because drugs like bevacizumab, which improve your outcomes, are then contraindicated because it's an anti-angiogenic drug. There's a high risk of perforation if you then give it with a stent in situ. So further on management, so radiotherapy, that's given in rectal cancers, so in high risk rectal cancers. So patients get 45 to 50 gray in 25 to 28 fractions, and you get 5-FU as a radiation sensitizer. There's a complete response in about 15 to 20% of patients, and this actually allows for rectal preserving treatment. So in patients where they have a complete response, you can actually opt to watch and wait. You survey them closely, and as soon as there's recurrence, then you opt for surgery. Obviously, the hope is that they don't get recurrence and they essentially don't require extensive surgery, thus improving their quality of life overall. Essentially, the time interval to surgery is generally 8 to 10 weeks. Again, Adam might have a different way of doing things. This is just what I've gotten off from the literature. And then there's local treatment options for metastatic disease. So you can resect liver mets, and there's systemic treatments as well as other local ablative techniques. There's also a lot at the moment of centers that are actually doing liver transplants for colorectal mets, but that's a whole separate talk on its own. In terms of systemic options, so it's just important from the beginning in that MDT to decide whether the therapy is going to be curative or palliative. Generally, chemotherapy is the backbone, and that's given with a biologic. So as I mentioned, the main therapies are 5-FU and then a platinum-based therapy such as oxaliplatin and then irinotecan. The biologics are your bevacizumab or your anti-EGFR such as cetuximab, and then just remember that cetuximab is also used in things like Menetriers disease. I know people like asking that in papers. I don't know why, because we never use it, but anyway. And then your immunotherapy, so that's your checkpoint inhibitors, nivolumab and ipilimumab, and those are the therapies that actually work in these microsatellite and stable or MMR cancers, such as your Lynch syndrome cancers. And then these, again, this is way beyond on us needing to know, but there's just various combinations of chemo and biological therapy that can be used, and that's just based on the molecular subtyping of the tumors. In terms of complications of therapies, this is very brief. There's obviously much more complications than just this, but surgical complications, so early you worry about things like a post-op ileus, an anastomotic leak, sepsis, a non-functioning or a high output stoma, and then late complications such as strictures, small bowel bacterial overgrowth. If you've done a right hemicolectomy with an ileocecal valve resection, you can obviously get backwash of the colonic contents, which allows for overgrowth. Patients can develop a low anterior resection syndrome, which is sort of a chronic pain and constipation syndrome following rectal resection, and then obviously bladder and sexual function, which will impact quality of life greatly. Complications of radiotherapy, again, both bladder and sexual function, as well as radiation colitis. Chemotherapies, the big ones is neuropathy with platinum-based chemotherapy, and then liver toxicity. Biologics, as I mentioned, bevacizumab can result in either GI perforation or a fistula. And then cetuximab and panitumumab, you can get diarrhea or constipation. So I think it's just important to be aware of these, because often you may be co-managing these patients with an oncologist, and they may develop GI side effects. And then in terms of the immunotherapies, patients can develop checkpoint inhibitor colitis, which again is a talk on its own, but essentially an IBD-like pattern, which varies from very mild diarrhea to fulminant colitis with a toxic megacolon perforation and death. So just very important to be aware of that as well. And essentially it's managed with withdrawal of the drugs, and similar to an acute severe UC type of picture. In terms of your prognosis, so your colon cancer 5-year survival, so stage 1, which again is very localized disease, there's no lymph node metastases, that's about 92%. Whereas you start looking at stage 3 and 4, your survival drops from 53 to 12% with metastatic disease. So in terms of your rectal cancer, there we go. Your rectal cancer, so stage 1 has a lower 5-year survival than your colon cancer, it's only 88%, but your advanced cancers is also quite poor overall with only a 13% survival. And then this is just a color chart. Again, it's just important that with localized disease, you have quite good outcomes at 5 years. With regional, it worsens, and then as soon as you have distant metastases, irrespective of your demographic group, the outcomes are very poor. That's it. So very quick, brief overall summary. And so if there's any questions, there's some time for questions.
Fantastic, Cecilia. I think that was a really great overview, and I mean, quite impressive for a medical gastroenterologist to sum up general surgery that quickly and easily. Makes me feel a little bit, I wish we could do it that quickly. Yeah, I just made a couple of points just as you were going on, things that just to emphasize that you said, but I think are really important. Just as far as diagnosis is concerned, you mentioned diarrhea, and I think specifically diarrhea and the presence of mucus is something that you should really take seriously. I think tumors, why you get diarrhea with a stoma is essentially, with a cancer, is the tumors tend to secrete a lot of mucus, and as the lumen narrows, the only thing going through is liquid. So that change in bowel habit to a looser stool is very concerning, and I think every medical student will tell you about constipation, but constipation is kind of ubiquitous. It's a looser stool is something to worry about. I think just to also reaffirm your thing, when you're tattooing, do not say proximal or distal, it's anal or oral, because proximal and distal is definitely in the eye of the beholder. So to the patient, it's very different to the person who's holding the colonoscope. So anal and oral side, generally we tattoo anal side, but as long as you document it clearly, and always document. If you're going to tattoo, always document and say, I documented anal side. Specifically, if you're tattooing for polyps, it must be 2 folds away from the 2 anal side of the tumor. So you don't want the tattoo to seep under the polyp, because the carbon in it also sticks the mucosa to the submucosal space. It sort of reduces that submucosal space. The other issue just about the rigid sigmoidoscopy, which we discussed before. So the huge difference between rectal cancer and colon cancer is in the pelvis, you can give radiotherapy, and you're very limited in the resection that you can do. So a T4 lesion in the colon, you just take out whatever's attached to it. In the rectum, you have to shrink that tumor down and use radiotherapy for that. How we decide on radiotherapy is with an MRI. How we decide to do an MRI is by doing a rigid sigmoidoscope. If you can feel the tumor, clearly it's in within 15 centimeters. You don't need to do a rigid sigmoidoscope. But trust me, when We see it all the time, tumor at 30 centimeters. And I get called to theatre by patients, they've done the scope, the tumor's at 30 centimeters, and it turns out to be a mid-rectal tumor. So anything 30 centimeters and below, 25, maybe 25 centimeters and below on flexi, you have to do a rigid sigmoid scope and find out, because half of those tumors are mid-rectal and they get an MRI. So don't be eluded, even though you think you've got a straight scope, it's got a curve to it, and you often get it wrong. I mean, I can guarantee you 25 centimeters on flexi-SIGI is more often than not mid-rectum. When you've got lesions, clearly, if you think it's a cancer, you must biopsy it. But if you think it's a polyp, something that could be removed endoscopically, please don't biopsy it. Photographs are good, film is better. Tattoo, if you're not the person to get it all out today, don't. And often these big polyps, I do quite a lot of big polyps, but if I'm scoping a person for a diagnostic scope or screening scope and I see a particularly big polyp that's high risk, I will often not take it out at that session, because I think the consenting process is slightly different when you do a screening colonoscopy consent compared to doing a consent for a large polypectomy, where all of a sudden, instead of going on a 1 in 2,500 chance perforation, you're looking at a 1 in 100 or maybe 2 in 100. So I do think sometimes there's a role to not do it at the same time. And it's far better to send the polyp to someone else than to take out half the polyp. It's a nightmare to remove. You condemning that patient to an operation that they don't need. You mentioned subacute bacterial overgrowth, especially after right hemicolectomy. I don't think it's a real thing. I think it's extremely unusual. You will sometimes get people that do strange anastomoses and you have a long redundant segment that you can get it. But I think that subacute bacterial overgrowth it's not something we generally see in right hemicolectomies, but it's spoken about in all the textbooks. What you also mentioned was anterior resection syndrome. So these are patients generally that have had low anterior resections, but any rectal surgery can give it to you. Having radiotherapy makes it worse. And anterior resection syndrome is a constellation of symptoms that include frequency, urgency, incontinence, and staccato stooling, and it changes with time. I think the really important thing is that when you have patients, perhaps as a medical gastroenterologist who has a rectal cancer, the first thing a patient's thinking about is, are they going to live and are they going to have a permanent stoma? And there's this huge thing. Obviously, no one wants a permanent stoma, but I think it starts early on that the person making the diagnosis can say, well, look, you might or might not need a permanent stoma, but just remember, there's a normal life with a permanent stoma. So I see patients all the time and it's, I'd rather die than have a permanent stoma. And you see them 5 years later with their follow-ups. And they say, I don't know why I made such a fuss about it. It's not such a big thing. And I think from our gastroenterology colleagues, we could sort of get that discussion, that mindset that a permanent stoma is not the worst thing. If you speak to most colorectal surgeons and you ask them, would they rather have a low anterior resection or an APR and a permanent stoma? Most would have an APR and a permanent stoma, because we see the problems of the complications and we see the problems of low anterior section syndrome. So while lots of patients do have good quality of life with a very low anastomosis, not all of them do, and there's significant risk associated with it. And then as far as just stenting and the biologics are concerned, I think it's a slightly overstated risk. We don't have huge experience in South Africa of the biologic chemotherapies, but remember that in the palliative setting, specifically, operating on a patient who's got metastatic disease is very dangerous. And the chance of a perforation from stent perforation from a good response to surgery, often even if they do perforate, they get an abscess, not a free perforation. And I don't think that it's contraindicated to stent if you've got access to biologics. I think that it is reasonable to do, but certainly you need to be concerned about it. We don't stent rectums anymore as a bridge to surgery, because if we give radiotherapy with a stent, we have had the odd perforation. But just remember, doing an operation on someone's metastatic disease has got the presence of metastases is an independent predictor of a poor outcome for the surgery itself, not just for the oncological survival. So I think that's all those are my very few comments, Cecilia, but I really thought it was a fantastic talk. Just going to have a look at the chat here. What's the guideline on screening surveillance? Screening for cancer, where we don't have, Cecilia, do you want to have a go at that first? Screening and surveillance?
No, it's okay, Adam. It's all over to you. I'm done answering questions for a lifetime.
For those of you who don't know, Cecilia did a certificate exam on Friday.
Yeah, so it's all over to you, Adam.
Quite impressive to actually have arranged a presentation over the weekend. So I think as far as screening in this country, we don't have a screening program. Cecilia alluded to it being unfortunate we don't. I don't think it's unfortunate that we don't have a screening program. I think we have no need for a screening program at this stage in this country. We're still a relatively low incidence thing. And I think the important thing to note about screening is screening programs, excluding colonoscopy, but other programs have been shown to reduce colorectal cancer death, but they haven't been shown to improve survival, all-cause survival. So although you won't die, if you enter a screening program, you're less likely to die of colorectal cancer, you are not likely to live any longer. Most people I know would go into a screening program to live longer, but clearly some are very averse to having colorectal cancer and so want to die of something else. But obviously you need to be powered a lot more to show all-cause survival changes. But the reality is that screening is a very expensive intervention that doesn't work particularly well. And I'm sure most of you will be aware of the rate of screening, and colonoscopy as a screening tool, which being invited to a colonoscopy was not more effective than not being invited. But if you had the colonoscopy, it did reduce cancer-specific survival. It did improve cancer-specific survival. As far as surveillance after colonoscopies, after colorectal cancer is concerned, a very controversial topic. There are a number of randomized controlled trials showing it doesn't make any difference whatsoever. However, we all know patients that have had liver metastases picked up and had them resected, so clearly it's a power problem, one would imagine. But I think the ACP, the Association of Coloproctology of Great Britain and Ireland guidelines say you should have a CT scan within 2 years of your surgery. Most American guidelines, and certainly in private practice in South Africa, do a scan every year for 5 years. Our routine examination is a 6-monthly CEA and then clinical examination, which I don't know what the role of that is, but we do it anyway. And I think in a CT scan at some stage or fairly regularly. But I think there's a lot of controversy, and you can probably do anything that you want. But I think the easiest thing to remember is probably just to do a CT scan every year. And mostly your liver metastases occur earlier, and most people would do a CEA 6-monthly. Although if your CEA was never raised, it's probably a useless test. But if the CEA was raised, dropped after resection, and goes up again, that's highly suggestive of metastatic disease. Are there any other questions in the chat? Anyone just want to shout out a question?
Adam, since the fellows are not asking, I would like to shout out a question. Is that all right?
That's fine.
Why, thank you. Cecilia, great talk. I have to agree with Adam that in South Africa, it's not unfortunate that we don't have screening. As he says, we don't need it. We think the prevalence is not as high that it would justify screening program. And of course, we have latest data showing that, well, maybe it's not as effective as we thought. But my question, Adam, is more a practical question for the fellows, but also just to see what you guys do. So if I'm scoping a patient for whatever symptom and I find a colon cancer, do you advise that in that setting, if I can surpass the lesion, I should do a full colonoscopy to look for synchronous lesions? Or if I have found the problem, I should biopsy it, and then the full colonoscopy will be done at a later stage when you're planning the management of the patient? What do you guys do, or what do you advise?
No, please do, if you can get past the lesion, please do a full colonoscopy, because we won't do another colonoscopy until afterwards. We always recommend a colonoscopy within a year of surgery, but we'd much rather not have to bowel prep the patient again. So we do want to look for synchronous lesions. We know that they occur in about 2% of cases. And so I think if you can get past, always get to the cecum, always document that you've got there, that there are no other polyps or anything that needs removing, and always tattoo the lesion The other thing is there's quite a lot of controversy as to whether you should take out polyps if you find any when you know when you've got a cancer. So let's say you see there's a splenic flexure carcinoma, but there's a polyp in the sigmoid. Should you take that polyp out? The controversy comes from the idea that's not really confirmed, but that you can get implantation metastases. So the tumor sheds cells, and if it finds a raw surface, it can implant on them. The other area would be, someone who's had a hemorrhoidectomy but has a cancer up above, and then it has been documented that you can get a cancer in the scar of the hemorrhoidectomy. So I do think that can occur. I think if you've got a polyp in the cecum and a sigmoid cancer, I would take the polyp off in the cecum if it's biggish. Remember, small polyps, you can take them off. You leave a small polyp in for a year or so. I don't think that's a big deal, so I wouldn't worry too much about that. And a big polyp, the surgeon might just decide to include that in the resection specimen. But please remember that in the era of laparoscopic surgery, we do want the lesion tattooed. I think we've got a hand up.
It's me. It's Gert from Merwe.
I thought I recognized that blue G.
Just a comment, maybe something to consider is just if you get a complication with the removing of a polyp at the time of your colonoscopy, then you do delay your patient's oncological management. So I have a patient on the list on Wednesday that had a colonoscopy elsewhere, a number of polyps removed, and he had a perforation. Fortunately, it was picked up on the scanning CT, no symptoms or anything like that. But I mean, that could have easily gone south. And I think one should be circumspect with removing polyps if you have a cancer already.
Look, there's no doubt that we have an epidemic of perforations at colonoscopy in this country, largely because of poor training in colonoscopy and scopes being done under GA. And so it's a world thing, but, you should be able to perform, average polypectomy should be incredibly safe, but I certainly agree, any kind of advanced polypectomy, one's got to be very, polyps take years to form cancers. There's no rush to get them out. I would, in general, if you've got any concern, I would leave that polyp alone, document it very clearly, and deal with the thing that's going to kill the patient soonest. I agree. Right. Any further questions?
I have a strange question from a non-surgeon.
Okay, let's go I like a strange question. Maybe I'll give a strange answer.
And probably I got it all wrong, but I think 2 weeks ago I heard something strange, something that goes like if a patient has got a colon cancer, whatever, and they have metastases to the liver. Some people apparently are removing the liver mets before they remove the actual cancer in the colon because apparently prognosis is better or something like that. It was the weirdest thing I have heard. Do I have the correct end of the stick? And can you please clarify that? Thank you.
You do have the correct end of the stick. So, if you think of what causes you to die, very few people die of colon cancer. They die of metastases of colon cancer. So the principle is, well, the thing that's threatening their life the most is the metastases. So if we can deal with the metastases, we come back and deal with the colon cancer. So that's always a decision taken in an MDT. Also, we know that if you have metastases, you do worse from your colon cancer operation. The chance of anastomotic leak, et cetera, are higher. And if you have, the cornerstone of your treatment, if you have metastatic disease, you've seen the survival figures Cecilia put up of like 10% roundabouts. So the cornerstone of survival is really all around response to chemotherapy. If you take out the primary and you have a complication and the patient doesn't get chemotherapy, then you've taken away the thing that's going to make them live longer or give them their best chance of cure. So we will often take a patient who's got an asymptomatic primary. Clearly, if it's a symptomatic primary, you must do something about it. We've got an asymptomatic primary with liver metastases. There's nothing to say that the primary will become irresectable soon, so it's not a massive primary or something like that. Then we'll look at this and say, let's test the patient with the biology of the tumor with chemotherapy. So we give the patient chemotherapy and see if they respond. We already know if you've got metastases that your chance of survival is fairly small. If you don't respond to chemotherapy, your chance of survival is incredibly small. So we say, test the biology, the patient responds to chemotherapy, right? Either let's take out the primary and the metastases at the same time. Let's say it's a segment 2 single liver metastases and you're doing a right hemicolectomy. Well, they're 2 medium-sized operations. Let's do them at the same time. Or let's say you need a right hemiapectomy. You've got an asymptomatic right-sided tumor. Let's do the right hemiapectomy and we come back 3 months later and take out the primary. And that's certainly, I mean, there's not randomized data supporting this. This is more philosophical mindset as to which you deal with first. We don't have evidence to say we should take the primary out or we should take the secondary. Generally, we look at the tumors and say which one is going to cause trouble soonest and try and get that one out first. But I mean, that certainly is the part of the decision making, bearing in mind that if you present with metastatic disease and colorectal surgery, there are about 184,000 treatment options. It is hugely complicated. You know, now this is in places where you've got multiple choices of chemotherapy, et cetera, et cetera. There really are a lot of treatment options. I mean, all the way up to transplant, as Cecilia said. So, you know, we can do the metastases at the same time, we can do them afterwards, or we can do them before. Right, is there anything else? All right, Professor Cecilia, I think you wanted someone else wanted to have a quick word about something. You wanted a moment, is that correct?
Yes. I'm sure you'll thank Cecilia, but thanks to both of you for a great presentation and just wonderful tidbits of really information that makes sense. Really, really appreciate it. Thanks, Adam.
Yeah, so just before we go to that, Mesh, I just want to say thanks to Cecilia as well, and then thanks to ECHO and UNM and the ECHO India team for the support. There's a feedback form available in the chat, and the recordings will be available on the Gastro Foundation website. And thanks to the Gastro Foundation. And remember, the next presentation is on the 14th of November, and it's on polyposis syndromes. So I think that's a nice follow-on from this thing. And polyposis syndromes are really important to medical gastroenterology, particularly because you guys make the diagnosis. Well, let's make the diagnosis. All right. So thank you, Rowan.
Where screening and surveillance comes in, certainly for this high-risk population. Thank you so much, Adam, and all of you. So Monique van Wyk from Janssen has just asked for about 3 or 5 minutes of your time, which is just as well because Cecilia got this done, you know, in good time. She just wants to show you a platform on their educational hub online where you can access radiology related to IBD, take quizzes, get a bit of CME, etc. So Monique, if you're online, I saw you earlier. Please feel free to share and just take the fellows through, you know, what you offer from an educational perspective. And thank you for the platform. Really appreciate it.
Evening, everyone. Thank you, Prof. Cecilia. I know everyone wants to get to their dinner, so I'm going to be 2 minutes. I appreciate the opportunity to just showcase to you an online learning program that we have launched recently by Janssen in collaboration with the TMC Academy called the IBD Diagnostic Imaging Online Master Tool. So this program offers you an image reporting simulator looking at the diagnosis, the differential diagnosis and monitoring of IBD. So it consists of 20 real-life patient cases, which includes a combination of different type of diagnostic tests, both gastroenterological and radiological, such as endoscopies, ultrasounds, MRI, and CT scans. And the topics that will be covered include the diagnosis and assessment of the severity in luminal Crohn's disease, using the different evaluation tools, identifying, assessing, and monitoring IBD complications, evaluating the transmural changes of the medical treatment for IBD, for example, comparing intestinal ultrasound images to MRI images, and also how to manage the hepatic involvement in IBD, just to name a few. So I'm just quickly going to show you here. It is accessible through the Janssen Medical Cloud platform, which I think the majority of you are very familiar with. It will take you to this third-party website. Sorry, let me just move all of you out of my way. Okay. So what is so unique about this program is that it allows you to practice in a real environment that replicates the work of specialists linked to IBD, image diagnosis, and monitoring. So on the left-hand side, you'll see there's different links available for learning material. And I'm going to open up, you'll see here are the 4 modules on the right-hand side. And just to show you one example, this on the left-hand side, you'll see there's a short clinical information about this specific case study about this patient. And then on the right-hand side, you can have different types of, sorry about that. Let's try this. Different types of way to view the imaging. So I'm just going to play around here. You can have a look. It shows you the imaging, however you'd like to view it in detail. So there is an introductory video elaborating on this. I'm not going to go into too much detail, but on the left-hand side, you'll also then see that there's some questions. And this is a type of learning by doing, which means that as soon as you have answered all the questions and you submit the answers, you'll receive the answers immediately. And if there's anything that you answered or interpreted incorrectly, the mentor online will give you annotations and a structured report on why and how you misinterpreted the images. So this strengthens the entire learning process. So I'm not going to take up any more of your time. What I'm going to do is I'll pop the link to this in the chat now. And like I said, it is also available on our Janssen Medical Cloud. And we hope that this will offer you some educational value. And please feel free to reach out to me if you have any questions to this regards.
Fantastic, Monique. Thank you so much. We really are enjoying the partnership with Pharma in terms of the educational mandate from both of our sides. And I encourage the fellows to use the platforms. We're just trying to offer as much as we can, more than we can do in our individual training centers. And there's so much that you can do asynchronously at your own time. So if you have any problem accessing the link or just getting onto the platform, you can email me and then I can link you up with Monique. But try it. I know some of the fellows have tried it and are able to easily log on and then just go through the questions. So once again, Monique, thank you so much. You did not take up too much time. It was actually quite lovely to hear you talk about that and go through that. I don't have anything else to say, guys. Thank you for joining. And once again, thanks to the presenter and the facilitator and Karen. And have a good evening. Enjoy your dinners.